Great. I want to thank all of our panelists. That was wonderful set of presentations. We do have about, let's say, 20 to 25 minutes if we stretch it left. So while potentially people in the audience consider what some of their questions might be and how they'd like to participate in this dialogue, while you're coming up to the microphone and formulating your question, I wanted to give perhaps Nina and Caroline a chance to respond to some of both the comments that our panelists have made and then some of the questions that have been posed. We had a lot of great comments, and I won't summarize them all, but several of the questions posed, I think, highlight on the concern over the move to country ownership, trying not to use the word transition at any point in this, the move to country ownership and the role of punitive laws or at country level and what are the mechanisms that can be used by PEPFAR to facilitate improvements in these and mitigate any potential harmful outcomes. The challenges around as we expand our understanding and merge the different prevention modalities, what does that mean for the already complicated process of trying to measure them, measure our outcomes and the effect of our work? And then a question just posed on the effect of the movement towards sustainability on our prevention, on the prevention work, and the role of prevention in that movement as well. So if you want to take some time to address those, and then we'll go to the questions in the audience.
So I just want to say that when we think about country ownership, we don't think of it as only government. So it's really civil society and government. And that mixture, sometimes we find ourselves like in places like Ghana, where the government and the Global Fund program has been very focused on general population. We see our role as strengthening civil society to look after populations that normally wouldn't have. Now, my understanding is in the new funding schema for the Global Fund, there is the opportunity in middle-income countries for funds to civil society for at-risk populations. So hopefully that will, yeah. And the other thing to say is it has been especially difficult in the countries of the former Soviet Union, having worked in Russia and in the stands and now in Ukraine, to try to continue to empower civil society. And I think that's where our greatest challenge is. We have been working with UNAIDS and now with Michel Kazakhstan as he takes on this role, a diplomatic role in the region. But I think, Vietnam, the limitation to methadone was a problem with the government, really, where they put limitations of about 140 people could go into a methadone clinic. So even though we got methadone through the country and did all the work to get methadone and set up the clinics, then we hit another barrier where they limit the people who go into the clinic. So it's continuously an ongoing negotiation with the government. And this, I think one of the problems that exists in the former Soviet Union is we look to trying to link care for those at-risk populations is that the systems are so stringently vertical that you end up having to look at an entire health systems, conversion. And that's been part of our problem too. Working with the police has been an especially difficult, it was in the former Soviet Union. In Russia, we tried. They closed down our NGOs like Sanam. And in Vietnam, we faced the problems with the detention center. But, we continuously tried to work with them. PEPFAR actually was one of the few programs left at USAID before they closed USAID in Russia. And it was just because it was one way to continue to have a dialogue with the Russian government was over health. So we certainly want to work. The one other thing I want to say is we say in our country operational plans that there should be what we call wraparound funding on needle syringe exchange. And we are very much looking to have those kind of partnerships like in Ho Chi Minh City with Médecins du Monde, I'm sure with OSI and other places too, because we really are looking for ways to make sure that there are clean needles because that obviously is the most cost-effective immediate intervention. It's also a very good way to bring people into treatment, testing, and care. And also, just so you know that it may look like 50% of the mandate is for 50% of the money in sexual transmission to go to abstinence and be faithful, but there is a clause that says you can write a justification that you don't have to do that. And so 16 of our countries have written this year for their FY13 COP a justification. So actually, there is less funding in AB than it would look like 50% because of the justification.
Just a couple of other things. I mean, I think that the budget codes are challenging because they often mask what are much more integrated programs that pull from multiple budget codes. The other thing I just forgot to mention that I think is useful is that FY13 will be the first year that we ask countries to report on the testing results aggregated from counseling and testing. So yield, how many people living with HIV did you test in this? And I think this will really help address some of the issues that you raised in some of those data issues, but I don't want to minimize them at all. I think this question about like how do we measure a comprehensive program, I mean, my colleague Shanti Conley standing at the microphone, she and I have been talking about this for years, and she has really, been pushing on us to do this well, and we need to do it better. The other piece I want to address is around adolescence, which Mike brought up. So I agree with you, and we are moving on a number of fronts to try both to improve the quality of programs for adolescents and to improve the data we're capturing about adolescents. And part of this is um, a collaboration with UNICEF that as moving forward that we're really going to push for global disaggregation by age, because part of the problem is we just don't capture those populations, right? We don't know how many of them we're seeing, and that really gets in the way of us beginning to tease out what our level of coverage is. I think there's a number of other big challenges with adolescents. I think it's important to know how many adolescents were perinatally infected versus horizontally infected, because sometimes those program needs are very different, and we don't have a good way to do that. And we also know now that probably more children who were born with HIV or perinatally infected during infected during breastfeeding are surviving than we previously thought. They're showing up in the health system later. We need to plan for those children. They have we hope they will have a long life ahead of them, but they're going to need those services. So I think there's some challenges there. I do want to say that this afternoon in the session on children and adolescents, we'll have more experts on PMTCT and on children, and I'll let them address some of the real issues that you brought up around EID. I think those are huge, and we recognize that we have a long way to go there. It's been a big challenge. It just pushes right at a number of very difficult commodities, logistics, keeping track, all those things that are really hard, and also the scale of a B plus. I think what we've seen in Malawi has been incredibly encouraging, but it's very early, and especially the issues around retention over the long term, we just don't know what they're going to be. But I think one of the most striking results out of Malawi is that so many women who were breastfeeding and HIV positive came forward and asked for treatment, which we did not anticipate. And that says that to us, I think that when you offer treatment in a decentralized model, which also gets at what you were talking about, Mike, that women will come forward for treatment when they can get to it easily. And Dorothy, this speaks also to what you were saying about needing to overcome some of those structural barriers, that when women can get to treatment easily and know that it's for life, that will help improve adherence. So not sure I hit all those points.
All right, I know that Mike wants to respond, but I do want to give our committee members just a moment to speak, because I know that time is never long enough in these items. So if you wanted to respond or have any comment.
I'd rather hear everyone's questions.
Okay.
I've definitely had, and one thing that I just want to say that we did conclude in the report is that the prevention approaches of the program have definitely evolved over the period of the program, both in response to new evidence as well as changes in views about what should be done in HIV prevention, and that was definitely a conclusion. We tracked that over the period of the program. So.
Is it brief?
It's very brief. I just wanted to say that's really encouraging to hear about having the concept of having B plus B available across the board for communities where it's implemented. I think one of the concerns is in settings that are potentially going to scale it up is, will it be available for everybody? There's a lot of word of mouth in communities, and if when it's in one community or another, but not another in these settings that are scaling up, this always causes issues. And something it's good to hear that it's being targeted from the get-go. Yeah.
Great. We have about 15 minutes left. I'll stretch everybody 5 minutes into
I thought we were going to 2:40. Oh,
2:15.
2:15. Oh,
So
we're already there.
we're almost there. So
Yeah.
we'll take 2 questions and then have a chance to respond,
So
and then take the last 2 questions.
I'm Shanti Conley. I'm the prevention team leader at USAID, so I'm a consumer of the report. And I talk to Nina all the time. So my question, I have 2 questions, and I'd like to direct them to the IOM committee. I think we heard today, both from Deborah von Zinkernagel in the example she gave us on PMTCT and Nina's example on VMMC, that there's a lot of convergence on the need to adequately address the behavioral and structural components of the biomedical interventions if they're going to succeed. I think this is a safe area, and perhaps there's less consensus around the issues relating to sexual risk reduction. And so it would be really useful to me to hear directly from the committee to what extent their recommendations for giving more attention to behavioral and structural interventions go beyond the behavioral and structural components of the biomedical interventions to actually behavioral and structural interventions directed at reducing sexual risk behavior. And I say that fully cognizant of the limitations of the evidence base. And then the second thing is that it would be really helpful if you could summarize, could give us some thoughts on how PEPFAR might set about identifying behavioral and structural intervention approaches for the settings we work in and the populations we work with, and also perhaps even a couple of examples of the types of intermediate outcomes illustratively you think we should be measuring. You know, I work for PEPFAR. I know we haven't always implemented these interventions as rigorously and strategically as we could have. And I do think we need some help in this area moving forward, quite honestly. So if you can give us some illustrative examples, that would be helpful. Thank you.
Hi, Jill Gay, whatworksforwomen.org, which is funded by both PEPFAR and Open Society Foundations. And my question is, both for IOM committee members and for the OGEC, for Carolyn and Nina, on the tension at the country level on what targets to meet. So for example, at a recent country visit, there was a lot of, we haven't gotten enough people on treatment. We need to show our numbers for voluntary medical male circumcision. And at the same time, we all of us know the gender issues in terms of PMTCT, and that women won't disclose to their partners because they could be beaten, they could be abandoned. And for example, adding to voluntary medical male circumcision a gender component, because that's where you finally get young men all in one spot looking at reproductive health. How would you address that? What would you measure? How would you make that happen?
Sorry about the technical difficulty in the middle there. It sounds like we may have temporarily lost our committee member on the phone, and I think that Lee is redialing her at this moment. So while we work to get her back on, and I apologize for the dial tone and number punching that will come up during the process, I'll maybe hand it over to our 2 committee members in the room on the 2 questions, or the first 2 questions posed, which were, to summarize, to what extent did the does the report address behavioral preventions beyond those and structural interventions beyond those simply involved in being synergistic with biomedical interventions? And then I know that this was a conversation that it comes up across all of the different areas in terms of what measures should be used, and could the committee recommend those? And I'd be happy to turn that over to you.
One of the things, I'm going to give this to Jenna some responses, but one of the things that I thought I heard also is say, what have we done to kind of respond to the vulnerable populations? And one of the things that was striking in talking to people in the different countries was the amount of dialogue that's happening about vulnerable populations. That even that it's a work in progress, and that so much needs to happen at the structural level and policy level, and that the dialogues are happening, and people are upset, and politicians are worried, and policymakers are worried, but it's all, this has really created a movement forward. And so that's encouraging for the future.
Because I have to answer the hard questions.
That's right. That's what you get.
So and if Dawn is back, please pipe up,
Yes.
because she, I'm sure, would have a lot to add. So to the first question on, did we look at the behavioral interventions to reduce sexual risk in and of itself, in other words, not just related to a biomedical intervention? Yes, and I think that was part of what the committee was concluding, was that it's not that we have to think about those interventions for the person or the population and unto themselves, and not just related to a biomedical outcome or a biomedical intervention. Having said that, I think I would pick up on something that either Carolyn or Nina said, that the idea that or someone said, the idea that these three areas are distinct doesn't really hold up anymore. And I think that's what and some of the evidence around that was emerging as we were concluding the report. So I think if we had concluded the report, I'll just speak for myself, now we might say something slightly different around ART's coverage scale up. But we were very cognizant that, to think about the whole person and the whole population and the types of interventions that they need to reduce their risk. And those are not always related to the biomedical intervention. One is related to that is your question about measures. We were not asked to come up with measures, nor did we. What we talked about was that PEPFAR, because of its size, has a real ability to set the standard about what those measures are. And the new technology that Chris mentioned, we're very excited about. I mean, I think to the extent that incidents can be measured more directly will be a huge step forward, and PEPFAR is in a great position to implement that and use it. I also, just even, we were talking at lunch, some of us, around treatment cascade concepts for different populations or within a country that can really help direct the system, whether it's OGAC or whether it's the country as well, figure out where the interventions need to be scaled up. So for different populations, it's going to be at different stages of that, getting people to know their status versus getting someone to stay and maintain care. So I think those are the kinds of things we looked at from the committee perspective. And then lastly, this is more about the sort of crossover between prevention and the sustainability discussion. I think inherent in the committee's view around sustainability and country ownership was that the role that the U.S. has played thus far in working with civil society, working with host governments, and working with the other donors and other in the country to make sure that the investments were focused on the populations that need them has to continue. I mean, it's sort of the idea that if that doesn't happen, then country ownership transition has the risk of losing the benefits that have already been gained, and I don't think that's the goal at all. So.
Gonna check in. Dawn, are you back with us? All right. It looks like unfortunately we've lost John, but that's all right. Jen did a great job in her stead. I think that we'll take, just to echo what Jen said on the measurement, which is that I think the committee really felt it could be a whole new 3-year committee in and of itself just to try and address these, but it's certainly something that was highlighted as a need. So. Oh, yes, I'm sorry. Absolutely. If you want to.
So, Jill, that's a great question. And I think, we are really actively engaged, especially speaking here for the Gender Technical Working Group, and I have my colleagues in the office, working with countries to sort of help get them past it's the either or, to seeing the role that taking these issues like gender-based violence and male participation into account will help them reach their targets. That's the whole point, right? These are the programs that improve overall program quality by eliminating the barriers that people face in using these programs. But it's a challenge. I mean, in many cases, we're talking about shifting the thinking of people who've been very focused in a certain lane or a certain approach for a while. And so I wouldn't claim that we have it, we've sewn that up at all. I think what your attention you're talking about is real. In terms of what to do and how to measure it, I think what to do, we feel like, we just recently published this guide on how to address gender-based violence across PEPFAR platforms. That's really designed in some ways for U.S. government colleagues in countries to help them figure out how to work with their implementing partners. In terms of how to measure it, I think that is more complex, and it needs to be part of this next iteration that we're talking about in strategic information for PEPFAR, where we look at elements of quality and we figure out the best measurement tools to elicit the quality that we're looking for, which also I think speaks to this question of, as we move into a different relationship with governments around running different parts of the program, how do we ensure that we have that quality is maintained at the same time that we also respect and understand that governments aren't necessarily going to run their healthcare programs the way the PEPFAR did. We were an emergency response and we dumped a load of resource onto the ground. That may not be realistic, but coming up with a model going forward that holds on to the most important elements, I think we're all very, very concerned about.
So we've technically reached the end of our time, but if everyone will indulge us about 5 more minutes of your break, and we're in the room with the food, so you've got first access anyway. So I know that Lee's got the questions from the webcast, so we'll take one question from the webcast, we'll take those, and then these two, and then we'll have our panelists wrap up.
All right, I have a question from an anonymous viewer. She asks, more than 98% of PEPFAR-supported ARVs are generics. What will be the effect of U.S. government trade and IP policies, for example, demands in the Trans-Pacific Partnership Agreement, that will make it more difficult to have access to generic medicines?
Thanks. Ted Hammett, Apt Associates. I think Jen actually got to one of these points just a moment ago, but I think it's really important, and that is the report's finding regarding the lack of quantitative evidence for the effect of these programs on biological and behavioral outcomes is really striking. I think it's a bit exaggerated. I mean, I think there is evidence, but I hope that in PEPFAR's new evaluation strategy, Nina mentioned focusing on coverage. Coverage is really, really important, obviously, both geographic and population coverage, but I think it really does need to look at incidence also. And there are new technologies, there are the lag avidity assays, there are multi-assay approaches, really exciting work that could be used to link up with coverage to make really, really powerful arguments, I think, and powerful evidence, as well as ecological approaches using secondary data and all kinds of things. That it doesn't have to be a really daunting or impossible task to look at incidence. It really can be done, I think, fairly economically and efficiently. So I urge you to include incidence outcomes as well as coverage outcomes in the evaluation.
Sharon Stash from the Center for Strategic and International Studies. My question is forward-looking, so again, it's probably more geared toward OGAC than the members of the committee. But I think at this table and other settings, I enjoy, actually, the aspirational language in around AIDS-free generation and the new promise that this narrower focus on high-impact interventions might build. Recent trips to the field, to Southern Africa, it doesn't sound the same there. And what I'm hearing at the field level is a different focus that has everything to do with declining resources and PEPFAR transition. What I'm hearing is we're overwhelmed with trying to keep the people that we started on treatment as PEPFAR leaves. That's our major job. It's a mammoth task. How can we keep the focus on prevention? That's sort of the general threat, is that it gets sort of pushed off under the table. The crumbs get brushed off on the side. But I think there are more specific threats among some PEPFAR secondments. We were paying a whole lot of salaries, including whole cadres of workers, community health workers, counseling and testers that have no place within the government system that's now being asked to absorb them or absorb their function in some way. So I guess my question is, how does OGAC, how does PEPFAR and its agencies keep a focus on prevention of any kind while we're in this context of competing tension?
Thank you.
All right, you've just come from Namibia, right?
Or South Africa.
And Botswana, okay. So I just want to address the first question, which was about incidence assays. So in the DHS pluses that we do now, or the AIDS indicator surveys, we have, since I would say the last 4 or 5 years, been making sure that they at least do the BEG assay with avidity. And in the one that they just did in Swaziland, actually we did pooled gnats, just because we wanted to have a more precise indicator for incidence. And we agree 100% that incidence markers are really what we're going for. The spectrum results that are calculated are helpful, but we'd really like to have some incidence biologic markers as well. And to your question, so there is, I would just to be honest with you all, there is a tension right now with decreasing resources about getting to the World AIDS Day targets. And I think, Jill, you hit upon it too. Do you take your investments and scale up your treatment program? Do you try to get to your B plus PMTCT program? Or are you trying to get to your targets for male circumcision? And we keep on trying to say, reach all those targets. They're all important and be very efficient. But I know it's causing anxiety at the country level. And for male circumcision, which we think is a tremendously important intervention, it's one of those nice interventions that you're in for a couple of years and then you're out again. We actually this year put in about $36 million from central funds so that the countries that felt they couldn't meet those targets could do so. And also looking to try to say what can we do centrally, such as campaigns or kits, so that what they're paying for is implementation at the ground and the other things are supplied. And in terms of the number of people who were, say, parastatal, either in Namibia or in Botswana, that's a very difficult task right now. And what we are looking at is how do we work with ministries of finance to talk about health systems, because it's not ministries of health that are going to get more healthcare workers. It's really trying to show what are the opportunity and economic costs of not investing in those personnel. So that's really when we were going towards it. And then I just want to leave you with a concern that I have, that I am sitting where I sit, and that is I am really concerned that there won't be enough testing and counseling kits. And we are starting to see shortages of testing and counseling kits. So we're working very hard right now to make sure we understand what that problem is and to have central kits. But we can have great PMTCT programs, we can have great treatment programs and male circumcision programs, but we need the testing and counseling kits. So that's an area of concern and that's what we're working on presently.
We are over time, so I want to thank everybody for your participation, both in the audience and then especially to thank our panelists who really made this. Oh, the generics question? Does somebody else want to field that?
Yeah, so we were aware.
I was trying to sneak you out.
So we were aware of those negotiations, and I'm not the lawyer. There's a lawyer at HHS that has been working with the subcommittee, but it has been a concern of ours for the last year or so, and I don't actually know what the implications are without speaking to the HHS lawyers.
So thank you all. We'll have a break until 2:45, and the next session will start at 2:45. They're still up on your slide here, and there are some snacks and still coffee and things off to the side. So thank you all again.